for helping make you aware of this potentially life-threatening condition. Now I'd like to introduce Deb Cleworth. You might know Deb. She is known about town. She worked for the Wisconsin Rapids Daily Tribune for many years, and now she's the community outreach manager with the Family Center. And tonight she is here to pick up all of the generous donations you made towards the Family Center.
Thank you, Nan. I don't know if anybody's going to be able to see me over this. We can see you. Okay, thank you. Thanks so much for having us here tonight. On behalf of our director, Sue Sipple, and all of us at the Family Center, I would like to thank you all for your very generous donations tonight. These items will go a long way to help victims of domestic violence as they move on in their lives, and also help keep our facility clean as we move into cold and flu season. If you caught my coworker out there, she was very excited to be accepting disinfectants and wipes, and you don't see that every day, so we are very grateful. Some of you here may remember when the Family Center got its start back in 1984 in the former St. Lawrence Catholic Church convent. We've come a long way since then. The new facility with 6 private bedrooms was built in 2004. We recently did some remodeling to provide individual offices for our advocates to better serve their clients with more confidentiality, and will soon undergo a renovation to provide a separate, more private entrance for victims. Since opening, more than 5,000 victims have been sheltered at the Family Center. In 2018, the Family Center served 438 victims, of which 52 received in-shelter services. We seldom have an open room in our 6-room shelter. Just this summer, we served 6 families, so all our bedrooms were filled, including 17 children. Imagine working on the level below them and hearing the pitter-patter of all those feet during the summer. While sheltering victims who are in imminent danger is a prime focus at the Family Center, we also work proactively to promote safe, healthy relationships. While our advocates can work with all victims, each has an area of expertise. Legal systems, sexual assault victim services, violence prevention, Hmong advocacy and services, children and youth services, and visitation and supervised exchanges. Recently, 2 new positions were added: a domestic violence housing first coordinator, who will work with victims to help them find safe housing or keep them safe in their own homes, and our domestic abuse services coordinator, who will be the first contact people have when they come to the Family Center. We also have a very important volunteer base who help us so much at the Family Center, from maintenance to donations to staffing the reception desk and more. If any of you are ever interested in spending some time, just give us a call. No job or time commitment is too small, and you can even volunteer on a one-time basis. We'd love to have you. As a nonprofit, we rely on grants, donations, and fundraisers to be able to serve victims. Our big fundraiser is Men in the Kitchen, and we have been honored to have Aspirus as a sponsor, along with some of Aspirus' own physicians as part of our chef lineup, and hope to have them again in 2020. It's set for February 29th this year, 2020, so it is leap year, so watch for information on our website regarding that. Along with the Boys and Girls Club of the Wisconsin Rapids area, we are holding a joint fundraiser this Saturday, August 24th, at the Grand Rapids Lions Club. Touch a Truck will feature trucks, semis, and more between 11 a.m. and 3 p.m. It's free to the public, so stop on by with your kids, grandkids, and just have some fun. The Family Center again wants to thank you all for your support and remind everyone that our services are available to any and all community members. Everything is confidential and at no cost to victims. Our director, Sue Sipple, loves to share the Family Center story and would be more than happy to come speak to any of your groups. Again, thank you so much for all your donations, and have a great time tonight.
Thank you so much, Deb. And now I'd like to introduce Hannah Walker. Hannah was a dietetics intern with Aspirus Riverview this year, and we'd like to thank her for helping us select immune-boosting appetizers that we were enjoying tonight. Hannah is originally from Sun Prairie and moved to Stevens Point to study dietetics at the UWSP. She met her husband through a university organization called CREW. She'll have to explain that. And they've been married since July 2018, so she's a newlywed. Her hobbies these days include cooking and watching old Survivor reruns with her husband. Please welcome Hannah.
Since I had to explain, CREW is short for Campus Crusade for Christ, so that was the organization that I met my husband in. But thank you all for having me tonight and for giving me the opportunity to meet with you all. I created tonight's menu to include a variety of different nutrients that will support a healthy immune system. The first menu item is the Mexican 3-bean salsa, which provides an excellent source of plant-based protein from the beans. Protein is required to build and repair tissues which is needed when fighting viral and bacterial infections. Beans also contain large amounts of fiber, which is a prebiotic. Prebiotics help feed beneficial gut bacteria, which support a healthy immune system by decreasing inflammation in the body. The dressing in the salsa also contains raw garlic, which is known to be antiviral due to a compound called allicin. However, the benefits from allicin are lost when the garlic is heated. The antiviral aspect of raw garlic may help protect your body from various viruses. The spinach artichoke dip contains 2 important vitamins needed for immune function. The spinach contains large amounts of vitamin A, which is needed to protect against gastrointestinal and respiratory infections. Some may not know, but artichokes are considered a flower and actually have 9 times more vitamin C than orange juice. The reason vitamin C is so popular when considering immunity health is because vitamin C stimulates the formation of antibodies which help fight against foreign invaders that lead to sickness. The blueberries in the simple blueberry crostini dessert are known to contain large amounts of antioxidants. One specific antioxidant blueberries contain in high amounts is anthocyanins, which are known to help specifically prevent colds. The finishing touch on the crostini is a light drizzle of honey, which naturally contains hydrogen peroxide, an antiseptic, causing honey to be an effective antibacterial food. I hope you enjoyed the menu tonight and will return home with fresh ideas on how to support your immune system through your diet. Thank you.
Thank you so much, Hannah. Can you see that she'll be a rising star? So Hannah is going to sit for her boards to become a registered dietitian. She is studying for them now, so let's all give her a round of applause. Next on our list is our aspiring a cappella. So I need to introduce them because they've not changed, but they've changed their positions or their careers. So Peggy is soon retiring. Peggy, there she is. I know, she didn't check with me first, but she's soon retiring and she plans to spend some time with her littles, which are her grandchildren, who she dearly loves, and going to Polka Fest, I think, because she, if you don't know it, she is has been on the cinema and the stage polking. Polking. Can you say that? Is that how you say it? Yeah. Kathleen Orminsky is still with Aspirus, but she's moved on up the road to Stevens Point, and she now manages their new ER in Point. Rhonda left our hospital building, but just went 1.5 miles up the road, and she is now at the doctor's clinic, supporting the clinic director and the managers there. And then Cindy left us. And Cindy is now doing HR work for Ascension at home. So ministry at home, ministry at home. So I think that that was a brilliant career move for her, and by the looks of her, she's very happy. I have to tell you that I need some of those Clorox wipes because these little women have left all kinds of germs on the podium. But I'll let you tell them about that.
Now, for those of you that know me, you might know that I love jokes and I especially love one-line jokes. So when I heard tonight was going to be about germs and infection, I couldn't resist digging up some jokes for you. So here we go, and shout it out if you've got it. Here we go. 2 bacteria walk into a restaurant. The hostess looks at them and says, "Sorry, we don't serve bacteria." The 2 bacteria reply, "But hey, we're the staff." Get it? Staff. All right, here's a toughie. Here's a toughie. Which runs faster, a hot or a cold? A hot, because anyone can catch a cold. Come on, these are good, right? Okay, here we go. All right, one last one. I know you're sad about it, but this is the last one. What is bacteria? What is bacteria? Are you ready? The rear entrance to cafeterias. You're welcome.
Doesn't get much better than that. By the way, we have been standing over here intentionally so that you could admire our new rhinestone denim jackets. How do you like them? Great. There will be a basket outside the back door if you want to throw a few bucks in, because we're kind of low on our wardrobe budget right now. We keep buying stuff just because we like to. I'm kidding, by the way. Before we sing our song, and Cindy has again came up with some amazing lyrics for you tonight. The name of our song is called One Germ. But before we sing it, we really do want to acknowledge that what you're going to hear about tonight is a very serious medical issue. So we don't want to lose sight of that. But at the same time, you know, we don't do serious well. We kind of like to do funny. So we have kind of a little mix of a song here for you. It's a little serious. It's got kind of a serious ballad sound to it, but some rather light lyrics. And we brought a few of our friends along, and we're going to introduce our friends because they're going to take part in part of the song. I happen to have my buddy E. coli, and I also have this bad boy, MRSA, MRSA, so they're my buddies. I'll pass it to Kathleen.
So my buddies are the common cold, and I got the good guy. This is the white blood cell. I have salmonella. And come on, can you guess it?
Pink eye?
What's it look like?
Pink eye?
Swine flu.
And I think I have the best ones.
Of course you do.
This one is the flu, but this one, I have diarrhea.
Too much information.
So we hope you enjoy.
Just one germ floating in my bloodstream. All it takes is one germ causing me to get a bad infection. I might need a big injection 'cause of one germ. I could get pneumonia, and I'd have to phone ya, so that I could see you in the morning. It came on without a warning. Oh, that one germ is tearing me apart. I wish that one germ would finally depart, so I'd feel better and get a brand new start and say goodbye to that germ. Da 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 It takes just one germ, just one germ floating in keep those germs away. Keep them away. Just one germ. It takes just one germ. Protect yourself. Save yourself today. Keep those germs away.
So thank you very much, we appreciate it. We'll take our germs with us.
The diarrhea thanks you.
Now you can see why I wanted to wipe off the podium. And then they threw the swine flu in my general direction. Next up, I'd like to introduce Peggy O.C. I don't know if you remember Peggy, but Peggy was the Chief Nursing Officer and Vice President of Patient Services at Aspirus Riverview, and she led us through many construction improvements, many new services. I got to meet Peggy, although she's my neighbor, I really got to know Peggy when I came on as the director of the Wound Healing and Hyperbaric Center, and she was a terrific mentor to me. Peggy is also the sister to Mike Windrock. So please welcome Peggy.
Thank you. I'd like to tell you a bit about our family's loss, which prompted this program tonight. My brother Mike, age 69, passed away on Wednesday, February 13th of this year after a very brief illness. He had some fairly common symptoms, including nausea, vomiting, chills, fever, and some intermittent discomfort in his right shoulder blade area. And that had been occurring since Sunday. Due to a number of circumstances creating basically the perfect storm, there was a delay in his getting to see a physician either in the office or in the emergency department. Those included a major snowstorm, and those of you that were in Wisconsin Rapids this winter know about those. An unplowed driveway, getting his vehicle stuck in a ditch, not wanting to call an ambulance, but most of all, not recognizing that his symptoms could indicate a life-threatening condition called sepsis, which could and would progress very rapidly. On Wednesday morning, when an ambulance was summoned, his heart stopped beating on the way to the hospital. Resuscitation efforts were started with some initial success. In the emergency department, a brief history was collected and antibiotics were administered, but by then, it was too little too late. As Nan said, I was the VP Patient Services and Chief Nursing Officer at Riverview and retired about 2.5 years ago. And one of the projects that we were putting finishing touches on when I left was a sepsis protocol for physicians and staff to follow. Those efforts were going on not only at Riverview but across the country because it was sepsis was not being recognized promptly and patients were dying. After this touched our family personally, I realized it does no good for the healthcare system to recognize sepsis and initiate an aggressive protocol if the patient and family don't seek timely care. By the time treatment was started on Mike, the antibiotic was literally like a spit in the ocean. It was too little too late. So our family, and Mike's dear significant other, Daria Skiba, who's also here tonight, we decided to fund this program to hopefully prevent another family from going through the untimely loss of a loved one. We ask that you share this information with your family and friends to get the word out about the need for prompt treatment. Also, since this is an audience of women, I thought I'd leave you with one last tidbit, and you're probably pretty well aware of this, and that's that men are only 2/3 as likely to go to the doctor as women. Why? Men tend to think they aren't that sick, and they don't want to waste the doctor's time, or they fear they're really sick, and they don't want to know that either necessarily. So what can you do to get your guy to go to the doctor? Nag. And in one large study, this is really true, in one large study they found that 19% of men admitted they finally saw a doctor to get their spouse to quit pestering them. So nagging is really important. And the other thing you can do is to remind him how important he is to you and to your family.
you so much, Peggy. I can't imagine that that was easy to do, but I really admire the fact that they are educating all of us on the signs and the symptoms. And so now I get to introduce our keynote presenters. First off, Dr. Tom Velker. Is there anybody in this room who doesn't know Dr. Velker?
Wow.
I didn't think so. I didn't think so. So Dr. Velker is the Chief Medical Officer for Aspirus Riverview Hospital and Clinics, as well as the Southern Medical Director for Aspirus. He earned both his undergraduate degree and his medical degree from the University of Minnesota. Go Gophers! No. Probably doesn't go over well in this room, sorry. And completed his residency in family medicine at the Riverside Medical Center in Minneapolis. Dr. Velker is a diplomat, we knew that, but a diplomat of the American Academy of Family Medicine and a certified physician executive. He was a respected and beloved family physician with a huge practice, as evidenced by everybody in this room knowing who he is, until the time he relinquished his RDD. Do you know what the RDD is? Real doctor degree. And moved into his full-time position as our Chief Medical Officer. Dr. Velker and his wife have 4 daughters and 7, actually it's now 8 grandchildren as of 4 days ago. He is a private pilot who also enjoys boating, wood fire cooking, and rafters baseball, but not necessarily in that order. Also joining Dr. Velker at the podium tonight is Becky Phillip, and she is the Aspirus Riverview Director of Pharmacy. Becky is a native of central Wisconsin, having grown up in the Stevens Point area. She attended SPASH, then University of Wisconsin Stevens Point, and then received her doctorate in pharmacy from the University of Wisconsin. Go Badgers! Becky began her pharmacy career at St. Michael's Hospital in Stevens Point and then joined the Aspirus Riverview family in 2003, and we are so thankful she did. In 2008, she became the director of the pharmacy at Aspirus Riverview, and she and her team run a tight ship. Becky has led the way on the adoption of an antimicrobial stewardship program, which is make sure that our patients receive the most effective antibiotics, which improves their outcomes and reduces antibiotic resistance. So the fun fact about Becky is that she used to own a flock of ducks, and each one of them had a name that was named after a drug. And Becky promised to pay me $1 gazillion if I can pronounce their names. So here we go. First one, Moban. It's used for schizophrenia. I had to look it up. Okay, I have to think about this. Tazorac. Yeah? Used for psoriasis. Taxol. Anti-cancer drug. Solumedrol. I knew that one. A synthetic corticosteroid if you're having a bad allergic reaction. And Cozar. Oh, $1 gazillion! And that's used for high blood pressure. So welcome, the two of you. Please come up and join us at the podium. I will hand off the mic.
Thank you, Nan. First of all, I felt a little unwelcome until just now when she welcomed me up here, because I noticed the first thing she said was, "Welcome, ladies." So duly noted, Nan. I do want to add one thing to Peggy's terrific comments. I think she summed up really the bottom line of what we want you to take home today. And that's when you get sick, and it could be sepsis, get in. We'll tell you a little bit today about how to figure that out. I was going to mention that men are stubborn. I hate to mention that, but they are. And the one thing I would add is do not hesitate to call 911. That's one other thing that men will not do, is let you call an ambulance. And if they're sick and you know it's sepsis, if they have sepsis, which we'll get to, there's a good chance they're going to die if we don't do anything. So even if they say, no, don't do it, call the ambulance will come, the usually guys in the ambulance will be able to talk them into coming in, and maybe you can all relate how mad he was at you at that point some other day. I do also want to say that my partners were gracious when they did literally take my RDD away. They allowed me to keep my MD, so I'm happy about that. The name of this program tonight is Don't Take a Turn for the Worse. So, don't take a turn for the worse. I welcome you all now in verse. I just wrote this about an hour ago. Don't take a turn for the worse. I welcome you all now in verse. I'm here to discuss germs, fever, and pus before you end up in a hearse. We just had our leadership retreat up north, and I had to for all of Aspirus, and I had to MC it. And so I started and ended every session with a limerick that I had to make up on the spur of the moment. So I am in practice. Sepsis. First of all, how big of a problem is it? 270,000 people in the United States get sepsis every year. When I get numbers like that, it's kind of hard to equate, yeah, but what does that mean? There's lots of people in the country. Wisconsin is a pretty average-sized state, and Wood County is a pretty average-sized county. So I divide that number by 50, and you get somewhere around 460,000 deaths, or cases and deaths in Wisconsin every year, or 46,000 every year. And then that equates to about 67 deaths in Wood County every year if you just average it out. So if you think about that, in 10 years, 670 people in our county are dying of sepsis. This is a huge, huge, huge problem. What is sepsis? Sepsis is simply any infection that makes you really sick. It overtakes the body. It's sepsis plus inflammation, or your body's response to the infection. And we'll get to which kind of infection can cause it, and the hint here is the answer is any infection. It goes by SIRS, if you ever hear that, but that's something we talk about. It's probably nothing you're ever going to hear about. Sepsis is the word to remember. And by the way, when I did lyrics for the whole group, they had to come up with the last word. So you might have to alter one of these words a little bit to come up with it at the end. So what causes sepsis? Again, it's got to start with an infection. And the song that we heard was terrific because what was the name of the song?
One germ.
One germ. That's how infections start. That's all it takes. You get your germ, you're not very sick, you get a little sick, you get really sick, and then you can die. If we can keep you from getting that one germ, we can keep you from getting sepsis. What is the number one way to avoid infections?
Hand washing.
Hand washing. Wash your hands before and after you deal with food. Go to the bathroom. Shake hands with Cindy who's got diarrhea. Wash your hands frequently. Have hand sanitizer. That stuff works really well. Just have it handy. And get the kids to get in the habit of washing their hands. Oftentimes it's not germs from you that get you sick, it's germs from the kids that are all over you. So if we can just all wash our hands, we're going to cut the pool of germs down, and maybe we won't get that one germ. So it can be in your teeth, in your stomach, pneumonia, a skin infection. There's a doctor on the east side of Wisconsin who's a friend of mine, and she recently got septic from a blood draw. She was in the hospital. They used alcohol, wiped her elbow, stuck the needle in, drew blood, just like all of us have had done probably many times, and she got an infection there. And the infection was treated pretty quickly, but it advanced to sepsis, and she needed a lot of antibiotics to get over that. And she did, and she's fine. But part of that is because she knows what sepsis is, knew she was getting sick. Probably the more important thing is that she was a woman, right. Okay, sepsis is broken down into three categories. Sepsis is where you have an infection and your body is giving that inflammatory response. You're getting sick, you're really feeling sick from it. Severe sepsis is where not only are you feeling really sick from it, but it now is affecting your organs. And it can affect lots of organs. Most commonly, it will affect the brain. You get kind of confused or slow thinking. Or the liver, which could cause abdominal pain more often. We find that because your liver tests are abnormal. Your extremities. When we get severely septic or in septic shock, which we'll get to, your blood pressure is dropping. Your body is trying to keep your liver and heart and kidneys and brain going, so it squeezes down on the arteries into your legs and arms, cuts down on the blood supply going to your hands. It's as if your brain doesn't care if your hand dies, but if your heart dies, you're gone. So because of that, you can get problems with the limbs too. Okay, the most important thing about sepsis, like I said, is getting in quickly. So it's about time. If your temperature is high, if you have a fever, you could have an infection. So you got to start thinking about that. If you're older, you might not get a fever. It's not unusual for older people when they get a significant infection to get a low temperature. So if your temperature is 96.5, that's probably really bad. It's like having a temperature of 103 or something. So if your temperature is not right, that's one sign. Do you have an infection? Usually when you're septic, you have an infection and it's obvious that there's a source somewhere. So if you've got a fever plus a cough, that red skin rash, diarrhea like Cindy had, any kind of an infection, if you just were at the dentist and you got that sore tooth, that could be the cause of it. What happens is that those germs get into your bloodstream and then that's what triggers the whole sepsis response. Mental decline, like I said, two reasons can cause this. One is the bacteria can get in the brain and actually cause your brain to start failing and getting sick. And the other is just because of the low blood pressure, you're not perfusing as much blood in the brain. So if you're starting to be slow thinking or not making sense, that could be a sign. And then when you're really sick, I just really don't feel well. I feel like I'm gonna die. Well, guess what? Maybe you are. Several times I have had patients call, I've got something going on, what should I do? And it's pretty clear to me when they call, they are really sick. And I say, you have to come in. We'll see you today, come in at 4 o'clock, or come in now, or we'll work you in. And the answer I get is, I'm too sick to come to the doctor. I would bet about 90% of people who say they are too sick to come to the doctor, who I did end up getting in, and I was able to talk most of them to come in, about 90% of them had sepsis. So if you're really, really sick, you've got to be seen. Becky's going to talk about what we do when you come in, how we can help figure out if it's really sepsis. But the key is if you're really, really sick, it's time to come in. Usually when someone has sepsis, they come in because they're really sick and we're able to figure it out. Peggy mentioned the initiative that she started at Aspirus Riverview to work on trying to find sepsis. And I was working side by side with her at the time. And what we found is a lot of people were coming in and we weren't recognizing it. So what we found on our end as healthcare providers is if you think of sepsis, you're going to find it. If someone comes in and they've got a red spot on their arm and they have a little fever and you're not thinking sepsis, you might just give them some antibiotics to take home and go see your doctor in 3 days. Well, with sepsis, if you are septic and go home to see your doctor in 3 days, either if you're lucky, you're coming back to the emergency room, and if you're not lucky, you're not coming back to the emergency room. So you've got to think about it. So our first intervention to try to cut down on our percentage of deaths from sepsis was simply to put signs up in the emergency room. Think sepsis. And so even from a health provider standpoint, if we're thinking about it, we're gonna get the right tests that can help us say, yeah, there's an infection and there are signs of inflammation. This is sepsis. You're coming in the hospital, we're gonna give you antibiotics. Again, the second point is call 911. You don't need to have a relationship with EMS. We have to have one, the emergency medical service, but you have to be willing to call. That's what they're there for. And probably the most poignant statistic I've ever read about sepsis is the last one. I tend to round up because I've heard this many times, and the number that I've been using is if you have severe sepsis, every 1 hour you delay getting treated is a 10% increase in your chance of dying. So if you're gonna wait for 5 hours until your husband comes home to drive you in, or until you can finally beat his head enough that he'll let you call 911 and get him in, if you're gonna wait 5 hours, you are now twice as likely to die as you were back when you first noticed it. So again, time is the acronym to figure out it's sepsis, but time is also what's really critical. In a second. I'm going to introduce Becky in a second. Actually, she's been introduced. I'm going to let her have the mic to tell you what happens when you get to the hospital. But first, you've got to finish this. If your belly hurts, it's just acid peptic. Have a seizure, then you're epileptic. But if a fever makes you quiver and it's hurting your liver, by golly, I bet you are septic. Very good.
Okay, thank you, that was very nice.
She's always like that.
All right, so now we've got you to the hospital, right? So we're gonna figure out what are we gonna do with you. We're gonna try and figure out what's going on with you so that we can control this infection and get you back to it. So, when you get here, we're gonna do a whole bunch of lab work on you. The first thing they're gonna do is draw your electrolytes. Then they're gonna draw some blood work on you to see what your blood counts are. They're gonna take a blood culture from you, see what's growing in there. One of the other things they're gonna do is look for a marker of infection. One of the things we look for is your serum lactate. That is one of the biggest markers of infection, and that's going to tell us the severity of your sepsis, and we're gonna track that over time to see how you're responding to therapy. We're also gonna start 2 IVs on you. One of them is gonna get a whole bunch of fluid running in it. The other is probably gonna get antibiotics and other medications to stabilize your state. Also, you're probably gonna get oxygen to stabilize your airway, and probably a heart monitor. We're gonna watch your heart. The other thing is the nurses are going to pounce on you with taking your vital signs. They're gonna watch your blood pressure, your heart rate, and your respirations. That's hugely important because that also is tracking how you're doing. We're gonna do all of these things to you within the first hour that you're there. Okay, so the 2 really big things that we're trying to do in sepsis patients is number 1, to restore perfusion to your organs. When you are septic, your organs, your blood supply is trying to shunt towards your organs to try and preserve those. You need your heart, like Dr. Belker said before. It's gonna kind of take it away from your extremities. Those are gonna get cold. We'd rather lose a hand than a heart or a liver. So your body is trying to put its blood supply to your vital organs. The other thing I want to do is kill the bacteria. I mean, that's what started this whole problem in the first place, so we want to get rid of that. The one really big thing, I forgot to say this, the bacteria that's causing your illness, it is so important to get a history of your present infection. Like what's going on, what happened, did you just have a C-section? Did you have a dental procedure a few days ago? I mean, we're trying to figure out where did it come from, so that's really important. So getting that history of your present illness is very, very important. Okay, the other thing we're gonna do, this is your, okay, here's your selections, you have to be real smart about this. Okay. See how he does. Okay, we need to, first thing we're going to do is restore circulation to your organs, right? For every kilogram of weight that you have, we are going to pour 30 milliliters of fluid in you. Okay,
How much is that, Becky, for an average person?
let me show you how much that would be for an average person. If you weigh 110 pounds, that is equivalent to 50 kilograms. You are going to get 1,500 milliliters. 1,500 milliliters. Hold on. I know. He's not doing well. All right. 1,500 milliliters of fluid. That's actually quite a bit for a small person. A 110 pound person doesn't weigh a whole lot. Well, now look at I lost my thing here. Right. Yes. If you're 165 pounds, we're going to give you 2,250. Harder on from here. There we go. That's what we're going to give you. If you weigh 220 pounds, you're going to get 3,000 milliliters, so that's 3 liters of fluid that we're going to pour into you within the first 3 hours of your visit with us. Sometimes there's a medical, sometimes there is a medical reason to not give you that much. If you have congestive heart failure, we certainly don't want to flood your lungs and make you die on this because we've given you fluid. So we're going to be really careful with that, and we adjust the fluid that we're going to give you.
However, you tell a doctor you're going to take somebody and give them that much fluid really quickly, usually the answer, at least during most of my career, would have been, no way, I'll kill them. That will go into the lungs, and you'll get fluid overload. It did take a lot of convincing of a lot of doctors that they need that fluid. You've got to give that fluid to fill up their blood vessels and get the blood going through the organs. And then once they start recovering, okay, now we got work to do because we got to get that fluid out of them. But if you don't do that first step, you're not going to have to worry about getting the fluid out of them. So it was, this is not just educating you guys. The sepsis work has been educating us as healthcare providers a lot.
Thank you. Okay, and that second thing we're going to do is we're going to kill that bacteria. So we are going to give you antibiotics. The antibiotics are like the cornerstone of sepsis treatment besides the fluid. And it depends. The antibiotic we give you is going to depend on where the infection is in your body, where the source was. It's going to depend on your history. If you've been taking an antibiotic for, to a week for some infection that you've had, and now you're here with sepsis, probably that antibiotic isn't working. We're also going to look at your other disease states, like if you have kidney problems or diabetes. And whether or not you got your infection in a healthcare setting, that's very important. Different bacteria grow in the community than do in the healthcare settings or nursing homes or assisted living. And we're going to watch your allergies, because we of course don't want to give you something you're allergic to. Antibiotics are the coolest thing ever. Ever, ever. The first antibiotic was discovered in 1928 by Alexander Fleming. Since then, there have been hundreds of antibiotics discovered. However, no new classes of antibiotics have ever been developed since 1987. That's a big deal. That's a whole bunch of years that we have gone without having any brand new classes of antibiotics. And a class of antibiotics is a different way to attack a bacteria. So, antibiotics target specific bacteria, and not every antibiotic will kill every bacteria. So this is just a very rudimentary diagram of a bacteria. But antibiotics act in basically 2 ways. Either they break down the cell wall, which is kind of like the skin of the bacteria, ripping its skin off. That'll kill it. The other thing we do is try to break down the DNA. So we go into the brain of the bacteria and we destroy its brain, which basically destroys it also. And we are watching you, big time. When you're in the hospital, our pharmacists are watching you, our doctors are watching you, our nurses are watching you. We're watching so many things on you. We're tracking your lactate to see how you're responding. We're watching your blood cultures to make sure what's growing out in your blood is actually going to be killed by the antibiotic that we have you on. We don't want you on an antibiotic that is not going to help your infection. Obviously, that is never a good situation. So we're always watching you. Okay, now you learn about life after.
So you survived. And now, once you're all done with your sepsis treatment, you get to go home. Anytime you're really, really sick and then you get better, you're not all better right away. If you have a heart attack or a heart bypass and you didn't actually have a heart attack and kill heart muscle, you go home, you're really weak for probably a few weeks. It's just hard on your body. So afterwards, you're not going to be back to normal right away. Partly because of that, people expect to be back to normal. They can get depressed and down, have trouble concentrating. But there is more to it than just that. There's something called post-sepsis syndrome. And there are kind of two branches to that. One we understand and the other one we kind of don't. The one we understand is where your body was affected, where the organs were affected. If your liver, remember sepsis is infection plus organ failure is severe sepsis. And if your liver was affected, you might not get back to normal. You might have some abdominal pain. Your liver enzymes might stay elevated, which would mean your doctor is saying no alcohol, watch certain drugs. There are different ramifications to that. You may not fully recover from the brain injury, confusion, memory loss, being really tired. Those could be direct, long-lasting effects from the infection. Also, limb pain, even sometimes leading to amputation of the fingers or toes. If the infection was bad enough that you cut off your blood supply long enough, you're going to get that. You could have chronic limb pain from it. The other part of post-sepsis syndrome, though, is not as well understood, but it's really more of a fatigue, depression kind of situation. And again, like we said on the last slide, it's not unusual. You were really, really sick, you were in the hospital, you get home, you might just feel down for a while. But with post-sepsis syndrome, that just doesn't go away in a couple weeks like you would expect it to. That can last a long, long time. The good news is we can do something about that, and the only way we can do it is for you to let us know what's going on. If you have sepsis, you will be following up with your doctor. That's a severe enough infection. We have blood tests we'll need to follow, so we'll be seeing you in a week, and 2 weeks, and 6 weeks, or something like that. If you're not getting back to normal, be sure you tell your doctor you're not getting back to normal. These things, the depression, the fatigue, they respond to medications like they would in other conditions, but it's just real common to have after sepsis and other severe illnesses. The last line is kind of telling. Julie had sepsis and was just scared she was going to get sepsis again. You never feel safe. Every time some little thing happens, you think, do I need to go to the hospital or is this nothing? What I told you at the beginning is a little bit confusing because I said if you get a fever and an infection, it could be sepsis. Well, lots of infections have a fever. If you get bronchitis, you might have a slight fever. How much fever is enough that you have to go in? There are no real guidelines. I think the key is if you have an infection and you really are feeling sick from it, that's the time you have to come in. When you're thinking, gee, should I go in? The answer is yes. Peggy had mentioned that we started this process at Aspirus Riverview to address sepsis, and we've come a long way with it. Actually, the whole Aspirus system is doing it, but it really started here with Peggy's work. And Aspirus Riverview is actually leading all of Aspirus in our improvements in our sepsis mortality. For those of you who don't know, System CMO, that's me, Chief Medical Officer, CNO, that used to be Peggy, it's now Kim Johnson, and the same people and others from all of the different hospitals at Aspirus are getting together and they formed a committee to really work on this. And one of the big things we came up with is standing orders, a standard order set for someone who we think has sepsis. And all the stuff Becky was talking about that we do in that first hour, that we do regularly, we recheck 4 hours later, how much fluid you get, That is all now standardized. So when you come in and they think it could be sepsis, that order set gets ordered, and you're not relying on people to think of sepsis and remember to check that lactate level and all those other steps. So it turns out that one step of standardizing the orders has really been the big mover in improving that mortality rate for sepsis. SEP1 performance has improved, and I'm sure only probably 6 of us in this room know what a SEP1 is. Medicare monitors certain clinical criteria on how well you're doing on certain diseases, and SEP1 is 6 different things that you have to do in order to be taking care of sepsis properly according to Medicare. And if you miss any one of them, you don't get the SEP1 criteria. And some of them are difficult to do, but some of them can be caught just by thinking about it, having it on the order sets. By doing that, we improved from only 20% compliance to 47% 2 years later, and now 2 years after that up to 67%. And the mortality rate for sepsis is clearly coming down. So this is not just a Riverview problem, it's not just an Aspirus or Wisconsin problem. This is all over the country, all over the world. Everyone's working on this. Was sepsis this bad when I was a young doctor? I'm certainly not a young doctor anymore. We saw sepsis, but we didn't see this much sepsis. I'm thinking maybe we just didn't recognize it, and people were seen and sent home on oral antibiotics, not enough treatment, and went home and died. So we now understand what's going on a lot better. We can do a lot better job treating it, but the real key is you guys all have to do a good job of getting it to our doorstep. This is coming to you? Yeah. Want to mention one thing that will introduce this last topic. We did see MRSA. Can't remember who had MRSA up here. Does anyone know what MRSA is? Methicillin-resistant Staph aureus. It's just a simple staph bacteria. It does what other staph bacteria does. If you get a little pustule, a little pus thing on your forearm, that's probably staph in there. The problem is MRSA is staph that's resistant to methicillin, which is a really strong antibiotic for staph-like germs. So if you get MRSA, you're in trouble, not necessarily because that infection is so bad, but we're going to have a heck of a time getting rid of it. Another one that wasn't mentioned was C. diff or Clostridium difficile. Has anyone heard of C. diff? Okay, that is, it's probably what Cindy had. It causes diarrhea. It's a bacteria that is around. A lot of people carry it, and sometimes it causes an infection, and it's bad. It's hard to get rid of. It's really bad on our end. When we get it in the hospital, it's probably bad on your end if you have it too. But it's also hard to get rid of, and it's highly infectious. Both of those infections, C. diff, or those germs, C. diff and MRSA, come from, well, what do we treat sepsis with? What's the number one thing? Antibiotics. And a little bit or lots of antibiotics? Lots. So we're in a quandary because we got to give lots of antibiotics. But if you get too much antibiotics, the bacteria get resistance and you get C. diff or MRSA. So this last part of the presentation Becky will come up with is, when is too much too much?
Okay, so Aspirus has taken on the challenge of making sure we control our antibiotic usage. And all Aspirus hospitals are doing this, all hospitals in the country should be doing this. There is an overuse of antibiotics in the world. I don't think that's a secret. There are people who go to the doctor and insist upon antibiotics. Some people will not leave the doctor until they get antibiotics. And maybe it's not appropriate every time. So we have these things called antimicrobial stewardship programs. They are created to make sure antibiotics are being used appropriately. There was a big push by the federal government, actually. There's a regulatory agency called the Joint Commission, and there's the Centers for Medicare and Medicaid Services that also put regulations in place that if you want to be accredited by these organizations, these quality organizations, you have to have these programs in place. Okay, so the big deal, the thing we're trying to combat here is antimicrobial resistance. Okay, so if you take an antibiotic that doesn't work against the bacteria that's causing your illness, that bacteria is going to morph itself, it's going to mutate itself, because it's trying to survive. And we're trying to kill it with these antibiotics. It's doing something different so that that antibiotic can no longer target that bacteria. Remember when I showed you that picture of that bacteria? So maybe before it was destroying the cell wall, but now this bacteria has morphed somehow. It's done something to itself. It's changed its structure so that bacteria cannot kill the cell wall anymore. So that's how we get antibiotic resistance. So germs, they try to survive just like the rest of us. So you get an infection. There are a lot of bacteria making you sick. That's all the little blue guys up there. And some of those bacteria are already resistant to the antibiotic we're going to put you on. So antibiotics, they kill the bacteria making you sick, but those resistant ones, they are not killed. And they are going to reproduce inside your body and have defense strategies that protect them from these antibiotics. So the antibiotic will not work on those. So they multiply, they continue to make you sick, and you get worse and worse. That's why we do all those cultures of your blood. We try to grow out what's causing your illness. We try to figure out what it is. You can do your part, though, to stop antimicrobial resistance. And I really want to go through this one, and I apologize for reading the slide, but I really do want to go through it. Don't insist on antibiotics if your doctor doesn't believe you need them. Most doctors are pretty savvy, and they do know what's going on with your body. Don't take someone else's leftover antibiotics to treat your own ailment. So Megan has an infection. It was a dental infection. Now Peggy has it. She said, oh, I'll just take some of hers because we have the same illness. Don't assume that it's the same illness, or your neighbor down the road, or somebody else, or maybe a family member who has died, saving their antibiotics for when you get an illness. Don't do that. Be sure you complete the total course of antibiotics that was prescribed for you. Often you'll start to feel better. Like right away, I'm like, I don't need these, they're expensive, I'll just save them for next time. Don't do stuff like that. Make sure you complete your total course. If it was a 10-day course of antibiotics 3 times a day, make sure you take a 10-day course of antibiotics 3 times a day. And throw out any antibiotics that were discontinued by your provider before the entire course was finished. Don't save them for next time. And don't skip doses. If you miss a dose, if it's close enough to the time, take it anyway. Don't ever double up on doses, but make sure that you are taking them as close as possible to the times you're supposed to. This is a big one, and this is why a lot of people come back with resistant infections, because they can't afford the antibiotic that was prescribed for them. And often they don't want to let their provider know that. It's embarrassing to admit that you can't afford your antibiotic. But please do so. I mean, there is alternative financial assistance for you if you are in that situation. So please let it be known that this is expensive for me, I can't afford it. We can get you some help or switch you to a different antibiotic. And check with the pharmacist to make sure it's okay to take yogurt or probiotics. Often, antibiotics will cause the problem that Cindy had with the diarrhea. Yogurt or probiotics are often really good things that you can do to prevent the bacteria, the diarrhea that might happen. And if you're not starting to get better, by around day 3, make sure you let your doctor know. Maybe we do have you on the wrong thing, and you need some little tweaking to that. We want you to be well. I feel like we should sing. But we do want you. I don't know. I think it would be fun though.
I thought it was going to be one germ, one special germ.
Not doing that. It was very good. But we do want you to be well. I know we talk about, coming in and getting everything done. Then the last slides we talk about don't use your antibiotics too much. And it sounds kind of contradictory, but we do want you to be well. That is the whole purpose for us to be here, to help you be well, and we certainly want that for you. Yes.
When you have knee or hip replacement and you go to the dentist, they give you amoxicillin.
So could you?
Stopped it, and they started it. So, you're getting amoxicillin just to have your teeth cleaned or dental work done a couple times a year. What do you think?
Her question was, often when you go to the dentist after you have a joint replacement, your doctor will give you amoxicillin to take before your dental procedure. And I'll try to take that one and then you can add if you'd like. Prosthetic limbs are really good harbors for bacteria. And when a bacteria enters your system from a dental procedure or something like that, it can migrate to the site of that joint and cause an infection there, which is why you are taking your amoxicillin as a dose. It's more of a preventative dose. It's kind of like the antibiotic that the doctor will give you before surgery. They're trying to stop the bacteria that is on your skin from entering the incisional site, and they're giving you that bacteria, or the antibiotic, just to kind of stop that from happening.
And I'll add just why dental procedure? Why don't you get that when you cut your arm? Why don't you take a dose of antibiotics? It just turns out that dental cleaning in particular, or more invasive dental procedures, not filling cavities, but cleaning or extractions, when you have that done, you do have some bacteria enter your bloodstream. Now, most of us are healthy and we get rid of those bacteria with our white blood cells, the one friend up here from before, but they do enter the bloodstream. So that single dose of amoxicillin will kill those bacteria off, not let them flow around in the bloodstream. And like Becky said, the hip and the knee replacement, those artificial items in your body have zero blood supply. So if a germ gets in them, all of our white blood cells that come to fight infections come through the bloodstream. There is no blood in there. So if the germ got in there, you're going to have a hard time fighting it off. And if your artificial hip gets infected, taking it out might be the only real way to treat it, and that's a really, really big deal.
I have a question. I had surgery on my knee, had C. diff. Now I'm afraid to go to the dentist because I have to take antibiotics, and I'm afraid the antibiotics are going to cause the C. diff to come back. So I'm really very, very scared about that. I don't know what to do.
I'm so sorry that you are frightened. I was hoping that you'd be enlightened. That's actually all I got right now. My best answer is don't be, and there are a couple of reasons for that. There are certain antibiotics that are really prone to causing C. diff. C. diff really isn't a resistant bacteria. What happens is you kill off enough of the neighboring bacteria in the colon that the C. diff can now take off and start overgrowing, and once it overgrows, it's hard to treat. Usually they use amoxicillin or erythromycin or similar antibiotics that really are not particularly prone to causing C. diff. It's also the single dose. It's prolonged courses of antibiotics that are much more likely to cause the C. diff. There's one antibiotic that we used to use a lot in the hospital for any serious infection. It's great for pneumonia and urine infections and skin infections. And it was so easy as a doctor to just write for IV Levaquin, and that cured everything. It also is one of the really worst antibiotics for causing C. diff. So we really, really try to avoid that now.
Do you tell people that they have sepsis? Because I had pneumonia 3 years ago this November, and a virus did save my life. But I had most of the symptoms you described, but I didn't know I had sepsis.
How long ago?
3 years ago this November.
Timing is good for that because yes, the answer is we should tell you. You know, we'll tell you have pneumonia, but you also had sepsis. But if you remember, 3 years ago was about when Peggy was getting this started. And back then we weren't thinking sepsis that much. So it really wasn't top of mind. Right now, I would think if you came in now with sepsis, I would be hard pressed to see you not knowing that when you left, that that's what you had.
When you're talking about antibiotic resistance, are you talking about just systemic antibiotics or also oral, optical, topical?
All antibiotics, yes. And it exists in all classes. There is MRSA, there's something called VRE, there's something called ESBLs now. I mean, these are like new resistant strains of bacteria that are occurring out there, and we have to be very careful, which is why we always want to track that you're on the right antibiotic, so we don't give those things a chance to mutate and cause a resistance.
So we shouldn't be using an antibiotic ointment either, unless we are getting an infection.
I mean, like on your skin?
Topical, yes.
Topical. I do. Because when you get a scratch or a cut on your skin, the bacteria that's on your skin is staph. Usually it's Staph aureus. And once that gets inside, I mean, you can have an infection that can blow up into something like sepsis. So it's good to grab it, nip it while you can. So put an antibiotic ointment on, that's totally fine.
But not longer than you needed. Just a fun little fact, I heard this on a public radio show as I was driving somewhere, and it was, how are we finding new antibiotics? There's one scientist who is finding all sorts of new antibiotics, not new classes like Becky said, but basically minor variants of antibiotics, and they find them on ants. There's an ant colony that is always getting into germs, and the ant creates its antibiotics naturally to kill the germ, and as they get into different germs, they have to create different antibiotics. So this guy cultures ants and keeps finding new bacteria and new antibiotics, and so then the drug company gets that antibiotic and patents it and charges you $390 a day for your 10-day course. And then you come to Becky and say, I can't afford it, what can I do?
Yes.
What about the theory that we shouldn't use antibacterial soap and hand sanitizers and all those things so much that we're actually not letting our body keep a resistance to the things that we encounter every day?
Yeah, that's a good question. That's out in the literature. It's kind of all up in the air. Nobody knows if that's the right thing to do. If it's not the right thing to do, are we killing them or are we making them more resistant? And I don't think anyone has decided on the right answer for that. In hospitals, we use antimicrobial soaps and cleansers. In restrooms here, maybe they do too. I don't know. But yeah, it's a good question. I don't have the answer. Do you have a better answer?
That was my answer.
That was his answer. The question was about antimicrobial soaps and cleansers that we use. Is that a good thing or a bad thing?
Thanks for asking.
Yes, sorry about that. Yeah.
Or scratches, or say a little, or just a cut of some kind. How about alcohol? Is that always a good thing to use?
I think that's fine. I'm not one who's averse to alcohol. But if you're talking rubbing alcohol, that'll work fine. I don't know of any problems with that. I do know one of the orthopedists. I know him well because this finger used to be about an inch shorter, just hanging on by a little thread on the side, and he put it together. And his recommendation was put nothing on it, let nature heal it. So as long as you keep it clean, that's an option too. Alcohol's fine, bacitracin or an antibiotic ointment is fine. Most important thing is don't overdo it. When you're better, stop, and then keep an eye on it. If it's getting infected, it's time to get it checked. And the question was, how about putting alcohol on it?
So if you've had a course of antibiotics for some reason, what do you recommend, or how long does it take for your body to build up the good bacteria again in your system?
That's a good question. There's a lot of work going on that. Pretty quickly, within a few days is probably the best answer. But on one of Becky's slides was the thought of using probiotics. And should you be taking yogurt with natural probiotics in it, or taking a probiotic pill? the jury is out on that. About a year ago, the teeter-totter shifted toward maybe that doesn't help, but I don't think it's wrong to do it, for the time that you're on the antibiotic. It's another one of those things that we'll have to wait and see what comes with the studies. And again, I apologize, you may not have heard the question. It's when you take 10 days of antibiotics, how long does it take for your body to get the natural good bacteria back?
I just have a couple things to add about when you get a fever.
If you're going to add, you will use the microphone.
When you get a fever and when you should seek medical attention, I think you need to look at the duration. How long have you had that fever? We all get bugs for 24 hours and they go away and you're fine, the next day. But if it goes on for 3 or 4 days and if it's a high fever, like in an adult, a fever of 102 is a high fever. So I think those are a couple of other things that might help you decide, do I see the doctor today or do I wait till tomorrow?
And sometimes you just don't know. There was one patient who actually I think kind of triggered our action at Riverview was a person who came in with some respiratory symptoms that didn't necessarily seem all that bad, and within about 24 hours had died of influenza sepsis. Now that's a strange one. Influenza is a virus that it's hard to treat. We treat symptoms, we give supportive measures if you have bad influenza, but any germ can do it.
Is there such a thing as overusing, like Lysol, cleaning your body your whole life with that? Can that destroy your immune system?
Is there such a thing as overusing Lysol or body cleansers? I don't think so. I haven't heard of infections from that. Do you know, Becky?
Because I have a friend that just has everything in the world that's going wrong with her, and that's the way she's been all of her life.
One of the problems is when, we hear that frequently, that somebody had this and nothing's working. When we do studies of what's right, what's wrong, we need to have hundreds or thousands of people to really know. So just on it happened to one person is hard to answer. And yet, there are changes now in recommendations for mammograms, and maybe you don't need them as frequently as we needed to. And do you really need that breast exam? Well, I always think of a patient of mine who came in just for a pre-op exam to get her gallbladder out. Was not there for her annual physical, but hadn't had a breast exam or a mammogram in 3 or 4 years. And I said, since you're here, we should do it. And she said, well, okay, if you think so. And I found a breast mass, and it was cancer, and it was removed, and she was treated, and that was about 22 years ago, and she's old like me, she still works at Riverview. So when something like that happens, it's natural to say, I don't care what those studies on thousands of patients showed, I'm going to tell my women that they should have breast exams. And I'm very confident, had I not done that breast exam, she would have died of breast cancer. That doesn't make it the right thing to do on everyone, but it really does taint your thinking. So that's the way humans are.
My husband is very convinced that that's what's wrong with her.
Yeah, and it could be, it's just one of those things, there's no way to prove it.
He should talk to the doctor.
Yeah, he should talk to
On the
the
side.
doctor, yeah.
Okay. I tried to tell him that.
Guys are stubborn. Weren't you here at the beginning?
All right. Thank you very much for having us and coming to our board.